Hi, I'm Dr. Anusheel Munshi. I want to thank Nalcon and I want to thank Dr. Prashant for having invited me for a talk in this prestigious conference. And over the next 15 minutes or so, I would be talking about SBRT as an alternative to surgery in early stage non-small cell lung cancer. We know stage 1 lung cancer, even though it's stage 1, it's very, very important to treat it. And a testimony to this is this very important publication, which showed that overall 5-year survival of untreated stage 1 non-small cell lung cancer was just around 6%, and majority died indeed of lung cancer. So for stage 1 lung cancer, what do we have on the table as treatment options? Surgery, which could include lobectomy, segmentectomy, wedge resection, RT, conventional or SBRT, and then RFA. Over the past 5 or 10 years, there has been a meteoric rise in use of SBRT. And this is for several reasons. We too have done 1 or 2 publications related to this to find out what these reasons are. And recently, one of the reasons has been the onset of the COVID-19 pandemic, which has actually augured the role of fewer fractions, and SBRT is definitely a modality that uses fewer fractions for treatment. So there is a physical rationale for use of SBRT, where you use multiple beams, create a hotspot, and then you have tapering and you have sharp follow-up of dose beyond that zone of interest. Head to head, if you compare SBRT and surgery, precision, excellent in both arms. Tolerability, excellent in SBRT. For surgery, depends on the performance status and other factors. There's no need for GA SBRT. You need it for surgery and you need PSC clearance and so on and so forth. Post-op recovery, not an issue in SBRT. Occasionally can take 1 to 2 weeks for surgery. The other consideration are SBRT is essentially a therapeutic modality, whereas surgery is in a way all-in-one. It does staging, it does diagnosis, it does therapeutic. So it's a kind of an all-in-one kind of a modality. Cost, SBRT would be having perhaps a slightly lower cost as compared to surgery. So what are the patient and tumor characteristics which of patients who typically come to us for SBRT? They are non-small cell lung cancer, usually pathology proven, small lesions less than 5 centimeter, no nodes or distant metastasis. However, they are also the patients who have poor performance status. They have associated comorbidities, and that's a fact of life. Most of these people have been refused surgery, and these are the patients who land up in our OPD for SBRT. And for various reasons, they have been refused surgery, whether it's compromised PFT, less FEV1, and so on and so forth. Salient features of SBRT: it's an outpatient procedure, 20 to 60 minutes per procedure. Entire course is over in 1 to 2 weeks usually. There is no sedation, there is no anesthesia, there is immediate return to activities, and very important, it's organ sparing. You don't resect any portion of the lung along with the tumor, so it can be considered an organ sparing procedure. Of course, we as a radiation oncologist divide our lesion into peripheral, central, and ultracentral. Central and the ultracentral lesions being the more riskier lesions to treat, although in no way not treatable. And that is because that as you go from periphery to the center, there are dose toxicity concerns for bronchus, trachea, esophagus, great vessels, and so on and so forth. And that's why we have devised risk-adapted fractionation. Going from periphery to center, we have kind of adjusted the dose per fraction in a way as to keep the safety factor of the patient in mind. And that has actually worked out quite well in radiation oncology for SBRT cases. We have also realized that lung is actually a very important organ, which also harbors a tumor which is moving most of the time. So the tumor is in motion because the lung is in motion. And that's why radiation oncologists also realized that they needed to have something to take care of this motion, to be cognizant, not only be cognizant, but also to take some kind of a measure so that they do not miss the tumor while it is in motion. So for that, you have different kind of modalities, including gating, tracking, breath hold, and so on and so forth. And they have really worked well in radiation oncology. And of course, one more important modality that has come up is MRI guided SBRT lung. And we had earlier offline approaches. Now we have MRI loaded on the linear accelerator itself, which is the online approach. While you're treating, you can take an MRI and then treat the patient, especially useful for I was talking about peripheral, central, ultracentral. So especially useful for central and ultracentral region where you want to have that window where the tumor is a bit away from those central structures, and that is the area that is the window time that you want to treat, and you can do it with use of MRI guided SBRT. I'll be talking a bit about evidence now, starting from the landmark RTOG 0236, which actually opened the doors and the gateway for use of SBRT in early stage lung cancer. We know the results of this trial were very, very encouraging, and SBRT was soon adapted as a standard of care in many situations. So we too published a kind of an systematic overview and analyzing and incorporating several studies. We could realize that the local control rates touch rate of around 90% or so in most cases. Of course, there have been series which have told us that the patients with central and ultracentral disease can have higher toxicities, but as I said earlier, we have taken care of that as radiation oncologists in our day-to-day practice now. Most of these studies also actually had patients who were non-operable. And that is also one factor that needs to be kept in mind as we're talking about SBRT, that most of these patients were non-operable and had been referred from the surgeons because they were not operable. So the natural question is, what about SBRT for patients who are actually operable? And then suddenly you see that for operable patients, the outcomes also become better. The 2-year survivals become better. The 3-year survivals become better. So, and this is another slide to further elucidate this point. So these, the columns in the top yellow are the surgical series of US, Japan, stage 1A and 1B. And on the right-hand side, you have the SBRT comparator arm. And you would realize that these figures are actually the same, whether you talk about the surgical series or these are the survival 5-year overall survival rates. So surgical series and SBRT series, almost similar 5-year overall survival rates. Driving home the message that comparable overall survival would be there if comparable patients are treated. However, I'm not saying that there is no evidence to the contrary, by which I mean that there has been some evidence, and some of which has been recently published, recently in 2021 as well, including, for example, this systematic review and meta-analysis, including, for example, this propensity score matching analysis, which have kind of suggested that surgery could be slightly better in terms of outcome, in terms of local control or survival. However, you also need to realize that most of this data suffers from heterogeneity, poor quality, and so on and so forth, and statistical issues. So I would say that we need to take this with a slight pinch of salt. There was a very important, in fact, a couple of trials which were started aiming to compare surgery with SBRT. They were never completed. However, analysis of these two trials, the STARS and the ROSEL, published in 2015 in Lancet Oncology, a very important article which published the overall survival outcomes and the disease-free survival outcomes. The top arm is the SABR arm of overall survival. The red one is the surgery arm. And you can see that both arms are actually quite comparable in their 3-year outcomes. So that is the important message that came from this study. And of course, recent studies have also attempted single fraction SBRT. And this is one such study comparing 34 grain 1 fraction versus 48 grain 4 fraction, and found that 34 grain 1 fraction also in a select group of patients could be used as a effective fractionation. So why I'm discussing this, especially because of the present pandemic times, when, for example, if we discuss surgery oblique SBRT in the present times, we know that there has been an unprecedented pressure on healthcare services. Elective surgical operations have been intermittently suspended. There is restricted access to surgery in some areas. So that's why the ASTRO expert consensus of radiation oncology, they specifically address the role of SBRT in operable patients when timely access to surgery was unavailable. And there was 100% consensus to offer SBRT in this situation. And there was also consensus for joint recommendations for ASTRO and ISTRO for single fraction SBRT in selected patients. Talking about central lesions, this is a snapshot showing the outcomes for central lesions post SBRT, slightly inferior compared to peripheral lesion, but nevertheless quite impressive and encouraging. As far as complications of treatment are concerned, if you take the example of the overview of the 2 trials that I just alluded to, in that overview, it was found that the grade 3 to 4 events actually were comparable in surgery, and SBRT arm actually was doing slightly better in terms of events. There was no death in SBRT arm, and 1 patient actually died of surgical complications in the surgery arm. So there was equipoise in overall survival, and toxicity profile was better with SBRT. Toxicity of SBRT, grade 3 radiation pneumonitis, 0 to 5%, radiation-induced plexopathy, especially for upper lobe tumors, in 1 to 2%. Late chest wall toxicity, this happens for lesions which are close to the chest wall and can happen in around 5 or 7% cases, which include chest wall pain, fibrosis, rib fractures, but fortunately it's self-limiting. Mortality, again, very, very low, less than 0.5% with SBRT. As far as failure patterns with SBRT is concerned, I'm presenting just 1 study, which, and there are a couple more, which tell us that most of the failures are not local, most of the failures are distant at metastatic sites. And so that could possibly be one more reason why patients are failing post SBRT. Most of them don't receive any kind of systemic therapy, as we know. They are either their general condition is so poor, or there are other factors which don't allow the use of systemic therapy in such patients. Our own experience, this was one of the first such experiences from an Indian center published from Tata Memorial Hospital many years ago, where our first initial 8 patients, we analyzed them and we found them that most of them were doing well. 7 out of 8 were surviving at around 2 years. 1 had died due to myocardial infarction. What are the possible upcoming advances in SBRT? I'm saying possible because we are still not sure whether they would actually be considered real advances. But the possible advances could be proton SBRT, flash SBRT, biology-based SBRT, artificial intelligence-based SBRT. Of course, the final aim is personalized SBRT to each of our patients. And of course, the studies that are going to shed further light on this SBRT versus surgery issue include the SABR tooth from UK, post-live from China, stablemates from US, Whaler study from the US. To summarize, there is robust data supporting SBRT in non-operable patients. However, long-term data is still awaited. Option for SBRT represents an option for operable patients who refuse surgery. SBRT is a valid alternative to surgery, especially in the pandemic context. And SBRT definitely presents a new option of care for early stage N0 non-small cell lung cancer. With those words, thank you so much for a patient hearing.